Hello, good morning, everyone. Welcome back to day 4 of our webinar series, Talk With Me. Today, we are going to talk about feeding. In day 1, we have talked about speech, oral motor, fluency, voice, and today we are going to talk about feeding. So the presentation will not take very long. We will have time to answer some questions and have some active discussion going on. So today we will have Yvonne, our speech therapist, to share with us about feeding, about what is normal feeding development, and some of the strategies that we use to help children develop feeding skills. So we'll welcome Yvonne. Yes.
Hello, good morning everyone. So I'm Yvonne, I'm a speech therapist with Summer Therapy Services, and I'll be doing a presentation today for Let's Talk About Feeding. So what will we be covering today? We'll be going through how as a speech therapist I support feeding, how typical feeding development should look like, what to look out for. I will also be talking about the different types of feeding difficulties and what it may look like. And then at the end, we'll try to address some treatment approaches or strategies that we can think about when we talk about feeding difficulties. All right. So before we start, if you have any questions along the way, please feel free to use your chat button below or the Q&A function in Zoom, and we will be monitoring and taking note of your questions. And as Hui Ting mentioned, we will answer them at the end of today's presentation. All right, so we will do our best to answer all the questions you have sent in. So what has speech therapy got to do with this? Now, actually, quite a few parents have been surprised when I ask them actually about what their child eats or what type of food that their child is eating, what type of spoon they're using. And I think not many people associate speech therapies dealing with feeding or swallowing. So I'm here to introduce and again say a basic introduction of what as a speech therapist I do, and I'm professionally trained to address. So I address concerns with regards to communication. I can address concerns with regards to language. So I deal with language development, communication development. I also work on speech development. And yesterday, my colleague has also gone through voice and fluency issues. And we are also trained to work with swallowing as well. So all these areas you see here fall under the purview of a speech therapist. So that is why we will also work with swallowing as well. So when we talk about oral motor, in my webinar presentation last Wednesday, we spoke about how speech and swallowing deals very closely with the oral motor process. So that is talking about the muscles in our mouth and the movements of it. So they are very intricately linked because they do share a common mechanism. What do I mean by that? That means they share common mouth. So if you think about it, swallowing involves the mouth. You have to chew and then it will go down to the throat. So here you have the throat area, and then you have the breathing involved in this process. And this is also what we do in speech. We have the mouth involved, the throat involved, and breathing as well. So we do have similar mechanism, and as a speech therapist, we are sort of in charge of areas below the nose and all the way down to the stomach. All right. Now, move on to feeding development. What do I want to look for in a normal feeding development for a child? So when your child is around birth to 6 months, I'm expecting them to be on a milk diet, and they'll be using more of the breast and bottle to be feeding from. So at this stage, their oral motor development is more of reflexes. They are doing the rooting reflex. You can look there. You can see when you place the nipple in the mouth, they will turn towards it. So that's a rooting reflex. And you have the tongue moving back and forth during sucking. So this is where the tongue is moving, going forward to activate the breast or the bottle to get the milk. Now, after 6 months, from around 4 to 6 months, actually, this is where complementary feeding starts to take place, which means I would encourage you to start introducing purees and expanding your child's range of taste. So this is where you can start bringing in spoon and cup to introduce different foods other than just milk. You can have puree, so they're very blended food, mashed up and blended very finely. And this will then also come hand in hand with the oral motor, and the reflexes will start to reduce. And because you have to learn how to manage a little bit different, not just a pure liquid kind of diet. So this is where you'll start to see the early munch chew patterns start to emerge. Children at this stage will be able to drink a small amount from the cup that is held by the adult. Of course, there will be spilling. This is absolutely normal for this stage. And the tongue, because it starts to deal with things that are not liquid only, they have different range of texture and taste. It will start to learn some control, and the tongue protrusion will still be there a little bit though. All right. But this is generally what we are looking at. The reflexes start to reduce. A munch chew pattern can start when we start to introduce things other than just a liquid. All right. So 4 to 6 months is a good time to start complementary feeding, which means it's not just only milk as the main. It's still mostly from on a milk diet, but you have additional foods coming in to complement and substitute already. All right. So from 6 months on, so 6 to 9 months, that is where I start to move away from total milk feeding and going towards more purees, more lumpy textures, and a little bit more towards more different solids already. So 6 to 9 months is what we call transition feeding. So it's moving from milk, the liquid only, to a little bit more milk and some purees, and now moving to more of the purees and introducing soft, lumpy solids already. All right, so this is important because when we start to introduce different textures, it starts to get the mouth and the gums to have that input, that sensory input and that texture, where it will also help in our dentition as well to erupt. In terms of oral motor control, we will learn, the mouth will start to learn, okay, I need to manage different types of foods, different textures. So not just only milk or the liquid texture, but we are also talking about different lumpy solids. Of course, they are softer now, still soft and manageable, but the mouth is getting an input of different textures. This helps with the sensory system as well. Okay, so when we introduce different solids, this is also where our utensils will be different. We will start to bring in more spoon feeding and not so much of the bottle, no more already at this stage. So during transition feeding is where I would say really start to wean off the bottle, okay? Because when you do that, you're actively teaching the child to let's incorporate more of the oral motor. The lips have to learn how to clear off food from a spoon. Your tongue will have to learn how to manage solids. With liquid, it doesn't need to do so much of that side-to-side movement. And then you have the more developed up-down munching pattern starts already. So all this can only start to begin to happen if we introduce the soft lumpy solids, we introduce some meltables for your child to practice on as well. So wean off the bottle around this stage. So I usually recommend no more bottle beyond 1 year old. And this is because it will discourage a mature swallowing pattern. So remember just now when we talked about here, the tongue is moving backward and forward during sucking when we are mostly on the bottle. If we continue being on the bottle after one, you're still encouraging that tongue thrusting pattern and you're moving your tongue forward. You cannot develop a more mature swallowing pattern where the tongue is at the back, is moving towards the back rather than towards the front. It may also promote tooth decay. So especially when your bottle feeding, a lot of the water is pooling near the teeth, and your teeth is being submerged in the milk a lot more. And some children, if they drink milk before sleeping, you don't brush your teeth, it will also promote teeth decay that way. And this is the one that I really wish parents would take note also, is the oral structures. The formation of your oral structures will also be obstructed. So remember, around 6 to 9 months, your first teeth start to come in place already. And if you constantly have that bottle there, it will lead to different tongue placement and a lot of different developmental issues when it comes to the structure of your oral cavity. All right. So in terms of speech also, the different tongue movements lead to different sounds that need to be produced as well. So I'll talk more about that later. So just what I want you to take away from this very strongly is that no bottle feeding beyond 1 year old. It is, if your child is developing in feeding, it's time to wean them off, all right? So around 1 year old, what I'm looking at is actually introducing straw feeding rather than still hanging onto the baby bottle. They should be using cup, they should be using spoon, they can start to use finger. And this is the time that I would say it's good to start trying to introduce the straw. By now, the food should be mostly lumpy or mashed in consistency. That will be the main diet that your child will be on already, not so much of the milk, all right? So more lumpy mashed food, and then your children, they will learn how to develop the oral motor. Your dentition will start to appear. Your front teeth usually appears at this timing. Your lips will curve around the cup, so you start to learn more precise movements of the lips. Your tongue starts to do more, it gets more practice so that it can move food from side to side in the mouth. And you're chewing, you will start to get that rotary movement where the tongue is moving things from side to side. You're not just the up down. So remember earlier on when you started the month chew, it was this usually more up down. Now you're doing the what we call the mature or more mature chewing pattern starts to emerge. And this comes with practice with more solid like food. All right, so lumpy mashed food at this stage. So after 1 year old, that is where your feeding, you start to develop more smoother patterns with the oral motor because your diet is more solid, moving more and more towards solid foods already. So around 1 to 1.5, I'm probably giving them more finely chopped table foods. So it helps them not to have to chew that much, but they are still learning how to chew most of the time. And by the time they are 2, I will expect them to be able to chew meat completely already. So if you think about meat, it's quite tough. You have to chew for a bit, for a while. And by 2-year-old, we can expect them to be doing that already. So feeding again becomes more independent. They should be able to hold the cup and tip it by themselves already. Of course, a little bit of spillage is okay for the motor control. But by 2-year-old, we are looking at more adult-like food already, no more liquids or milk as their main food. So this, because you're getting that practice with these different food textures, these solids, this will lead your oral motor system to mature as well, and you're starting to get more fluid and smooth movements. So your chewing becomes more coordinated, your tongue gets to get more precise movements. So your tongue blade and your tongue tip. So the tongue blade is the body of my tongue, and the tongue tip is the tip. So you're starting to get more segmented movements, even in the tongue itself. You're drinking, you're able to drink 4 to 5 consecutive swallows as well. And straw drinking, you are able to drink for a longer time, and tongue retraction happens a lot better. Lip closure happens. So between 1 to 2, this practice period with solid foods, they are very important, and it's good to mature the oral motor system as well. All right. So with that, when your oral motor system develops, it will also translate to our speech as well. We have the oral motor system ready for speech. So sometimes when I look at certain of my children who I was working on a speech issue, and I look at, what are they doing at feeding? And then I realized, they are still drinking from a bottle, and that's why they are doing the tongue forward movement. So they are intricately linked. Sometimes the what you provide as the food can impact the speech, and sometimes what we are doing there in the oral motor system can impact how they manage the food as well. So be aware and be mindful of what to look out for feeding development. Don't leave your child at the milk stage all the time. Move them on consistently. Introduce table food. So aim by the time they are 2, I want to be seeing them more on an adult diet already. We shouldn't be giving them more baby-like food or mashing up too much of the food for them already. So this is typical feeding development for a 2-year-old. They are able to manage most adult diet. Okay. So now that you know what to look out for a typical feeding development, let's look at some feeding difficulties that we may face or we may come across. So sometimes in my practice, we have parents coming to me and say, you know, my child just doesn't like eating. Meal times are difficult. So there can be many reasons why mealtime is difficult, or your child may be fussing around or difficult to sit down and eat. So some of it could be a structural issue. So children with cleft lip, cleft palates, or sometimes a tongue tie may also affect the ability to move and manage the food in the mouth. There could be oral motor difficulties as well. So the jaw may not be able to be strong enough to chew the biscuit that you give them. And that may also then lead to food refusal, where the child just doesn't want to eat food. So there are cases where, of course, it's purely food refusal or purely an oral motor, but most of the time, by the time it comes, we do see that they are linked, like they are interrelated. So for example, a child who is demonstrating a lot of food refusal, you just put the food on the table and they cry and they, push the food away. That may be what they are showing now, but it could have been because the first time it was due to an oral motor difficulty, which means their mouth couldn't manage the food the first time you gave it to them. And when they tried it, they learned, oh, I almost choked, or I couldn't manage this. And they learned then to say no to this food. So sometimes an underlying issue could be an oral motor difficulty as well. And we need to be very, very clear which one is the issue, or what are the different issues that are at play for your child's difficulty with feeding. So with this, it will require a lot more detailed observation and, of course, an assessment by your speech therapist to really pinpoint what could be the different areas at play. All right. But what I want you to take note or take away from this slide is that there are different underlying reasons, and they could be interlinked as well. Okay. So now let's talk about swallowing. What is swallowing? Essentially, it's a very easy definition. It's moving food from the mouth over here to the stomach. So swallowing process is the whole process. Some people will think it's just that part. Yes, but anything from the mouth, it's the start of your swallowing process already, and then it's moving your food from the mouth to the stomach. So we will commonly divide it into 3 or 4 phases, depending on which therapist you're talking to, but it will include the entire phase. Okay, so we have 4 phases. The oral preparatory phase, where it is mostly in the mouth. We have the oral transit phase, so we are moving the food from the front of the mouth after we are chewing and making sure it's okay and ready to swallow. We transit it to the back of the mouth and get ready for a swallow. And then here you see the white color part, and that's where the food is going down the throat. Here is when it's going from the throat to the stomach. Okay, so if you take a look at these pictures here, this is what you'll look like if I cut myself in half and I look. So this is the nose, this is my lips, this is the teeth, this is the tongue, this is my jaw, and this is the back. All right, so this is my throat area, this is my mouth area. Okay, so the white color thing here, this one is the food. All right, so this is the 4 different phases that we will talk about here. You from the mouth, you move to the back of the mouth to get ready for a swallow. Then you move, and here it starts the swallow already. It's already at the back of the throat, and it's going down to the stomach. So what is dysphagia? Dysphagia is when there is a difficulty present in any phase of swallowing. So any of these 4 phases in the mouth, moving to the back of the mouth, at the throat area going down and going down from the throat to the stomach. Any of this area, if there is a difficulty, this is what your therapist will call a dysphagic swallow or having dysphagia. All right. So dysphagia is when there is a it's not going through the normal process or it's not going through the process we want it to. So typically the food goes down here. This is the food pipe. This is the air pipe. All right. Here it goes to the lungs and here it goes to the throat, back of the throat to the stomach. Now I want you to notice this area here. This is the what we call the back of your throat here. This area, if you notice, it is a free entryway. The air pipe and your food pipe, there is not a very clear distinction. There is clearly anatomically distinct, but the food has a risk of going into here while traveling to the food pipe. Your windpipe is here, okay? So during the swallow process, this thing will flap down and close up the windpipe and protect it so that the food will go down to the food pipe. But sometimes that doesn't happen and the food goes into the windpipe instead. So where the air is supposed to be going, the food, instead of going to the back, it slipped into here. So this area is where it's difficult and it's tricky and can have dysphagia. All right. Now we look at swallowing. What I want you to take note is the 4 phases again. If you look here, first 2 phases is where it is voluntary. Okay. What I mean by voluntary is that this is where my brain can decide, okay, I want to stop. So if you think about it, if I'm chewing at my first phase in the mouth, I'm preparing my food here, right? This white thing here is the food. And I'm chewing and preparing the food. And I can think, okay, let me pause for a while. And I can stop that process. And that is voluntary. My mind can control, okay, I want to stop that chewing for a while. Now think about holding the food in the mouth. And I think, oh, if I don't want to move the food to the back of my mouth to swallow, I can stop. I can pause also. And I can think, okay, I want to pause. And maybe I want to chew some more. Or maybe I want to hold it in my mouth. So these 2 phases, oral preparatory and oral transit phase, is where I say swallowing is voluntary. These 2 phases at the back here, you see pharyngeal, so where it's going down, and esophageal, where it's going to our stomach. These phases is where it's more automatic. So this is where the brainstem takes over and other swallowing areas in my brain takes over and makes it automatic. I cannot swallow halfway and say, stop. Once the food reaches here, it is automatic. The body takes over. It's just like breathing and our heart beating. We cannot say, okay, stop it. It's an automatic process. Okay. So as a speech therapist, what I work mostly on in clinic is these 2 phases. The voluntary phases, where in the first phase, I chew the food and mix the food with saliva until it is stuck together and ready to swallow. So if you think about eating a biscuit and you're biting it, you will first break apart the biscuit and you will bite until it is ready to be swallowed. And if you think about it, before you swallow, you can pause and it has become a lump. It is usually a ball here. And that is when it is ready to move towards the back. So the first phase is where I'm really chewing, mixing it up with enough saliva, breaking up the food. And here also I have to prevent the spillage. I make sure the food doesn't fall out of my mouth. I'm closing it, chewing and mixing until it is ready. And then in the second phase is where I move my food towards the back of the mouth. And this is where I trigger the voluntary swallow in phase 3. So all this, it takes a very short amount of time. This oral preparatory phase would be the longest timing, all right, where we involve in chewing and breaking it down properly. So as a speech therapist, I can work on this part where we work on the jaw, the lips, the tongue, because this is the oral musculature that is involved when I want to prepare the food. Your jaw has to chew, your lips is keeping the food inside, your tongue is moving your food from side to side. Your teeth, your hard palate, and your cheeks are also involved to make sure all the food is moved to where it needs to be. Okay, so if you've joined me in the oral motor webinar last Wednesday, this triangle will be familiar to you. So again, we work on the jaw as the foundation first, because that is where the lips and the tongue rest upon. So if you look at the structure of our head, the jaw is here supporting our lips and our tongue. So when I work at dysphagia at an oral phase, this is also what I'm looking at. I will work this way. All right. So now you know what is dysphagia, you know what is normal, typical feeding development. How do you know if your child may be having dysphagia? These are some of the red flags I commonly ask parents to take note. So if your child is coughing during meal times, so this can be after you swallow, after you give a spoon, and maybe even 5 seconds later, and then they cough. This is something you need to take note of. Anytime there is coughing within a meal time, it is something that we want to take note of, because remember the visual I was showing where it could have gone into the windpipe, and the body's natural reaction is to cough and try to get that food out of the airway and back. Okay, so if your child is showing gagging, choking, vomiting, or reflux issues, these are also red flags that there may be dysphagia going on at any of the phases. If you notice a change in breathing rhythm or turning red or blue during feeding, again, remember, when the food goes to the air pipe, this tells me my oxygen supply is disrupted. So this is where if I look at my child, before eating, they are breathing at a steady rate. And then after they start to eat, the rhythm changes, either faster or slower. There is a change in the rhythm. I want to be mindful, because that could mean, again, dysphagia. If you see them turn red or blue. So the areas I tend to look out is the ones under the eyes and above the eyebrows. Over this region here is the thinnest area, and you can see the change in color the fastest. So be mindful, look at your child when they're eating. Are they turning red or blue? Is their breathing rhythm changing? This could be a red flag of swallowing difficulty. Okay, and if you say no, don't have any of those, do they have frequent chest infections? Because sometimes they don't show it or we don't pick it up, and all the food that's going into the lungs, this could be causing the chest infection as well, because it's foreign bodies inside our lungs. So if your child frequently has chest infection and you're not sure why, one thing to take note is there anything going on in the feeding? Okay. If there is unintentional weight loss, so if you're feeding, but you're not able to gain weight, and even worse, you're losing weight, this could be a red flag as well, okay? So take note when you're feeding them or when they're feeding themselves, after they swallow, is there food left over in the mouth? Or if they need to swallow many times to clear the food that is in the mouth, this could be also a red flag that, remember the oral phase where you're supposed to prepare the food so that it's all ready and put together in a ball-like thing to be ready to swallow, that process didn't happen well enough, and so you're only swallowing part of it. Or it could be that I'm swallowing a little bit and it is still stuck in my throat. It is not strong enough to go down to my stomach. So all these could be signs as well that we need to take note of. If their child is again having resistance to meal times, or it's long and effortful, every time they see you put a banana on the plate, they run and cry, they flip. So this is a sign that it may not be just a behavioral issue or they're being naughty. They could be really telling you something is really not right in the feeding. It is difficult for them. This is a red flag for us to take note of also. Okay. So now we know the different types of feeding difficulties as well. Let's talk about some treatment approaches, okay? So remember I told you there are many different reasons, and it could be interactive, a combination of both reasons of why your child may be having a difficult mealtime. So if I'm having food refusal, as a therapist, I would want to think, okay, I can use a sensory approach to feeding. I can use a bed training approach if it's more of a pure food refusal issue. If it is more of a pure oral motor issue, I can do some pre-feeding program and build a program for them. I can do therapeutic feeding. We can do diet modification also. So there are many different types of feeding programs we can do and construct. At the end of the day, in order for me to choose which approach or what part of each approach your child needs, I would need to know what is the underlying cause or what is the main issue your child is facing as well. So unfortunately, these will all require, I would think, a webinar of its own. So I won't be able to go through the fine details of what goes into these approaches. What I would want you to appreciate is that it is not so simple. It is a complex, customized approach or customized feeding program when we work on feeding issues. Sometimes we can take both and put them together. Sometimes we need to work on one before we can work on the other. So this one, I would say we really need to talk to your speech therapist. You need to be properly trained on how to do this before we can apply or tell you, oh, what approach your child can be using, okay? So instead of telling you what treatment approaches, you're like, Yvonne, I sat through all this and now you're telling me I can't do anything with my child. So not to worry, I have some strategies that you can take note for today. So even if your child, you say, oh, my child, you know, you went through the feeding development, my child is on track, my child has no issues with that. These are some strategies and tips that I think everyone should be aware of and would benefit you to be mindful of these two things. The first thing is high-risk choking foods. And the second thing is a note about what to look out for posture. Okay? So, high-risk choking foods, what are these? The whole chart is here for you and you're going, Yvonne, that's too much information. Don't worry, I will pick two main texture or characteristics of food that I want to talk to you about, but I just wish that you would browse through and just glance through this chart and have an understanding that mostly we are talking about things that are chewy, that are tough, that may have small parts. The main idea we look at is things that have maybe short, small, hard, or tough parts for the child to manage. And these may be choking risk as well. If you want to find out more detail or you want a list, you can search up IDDSI on Google, or you can just type high-risk choking foods. You can get a lot of them as well. Or you can also always contact us and we can share this table with you. All right. So the two main high-risk textures I like to talk about. The first one is mixed textures. Okay. So mixed textures, what are they? It is when there is more than one type of texture in one mouth. For example, pasta soup. You have the soup, which is liquid, and then you have the pasta, which is solid. So this is what we call a mixed texture because the mouth now has to manage more than one kind of food. It has to deal with the liquid. So when I just deal with liquid, my mouth needs to do one thing. But I also have to deal with the solid. I need to make sure I don't swallow the solid, the pasta, together with the liquid. So not only must I know how to chew the solid, I must know how to hold the solid and then swallow the liquid first, and then chew the solids until it is ready, and then swallow. So it requires a lot more coordination. My mouth movements, oral motor, it requires a lot more intricate movements. So if you have poorer oral motor skills, it is very likely that you might choke on something like this, where there is two different textures in one mouth. So think about fruits. These are commonly, people don't think about fruits as having mixed textures. But if you think about a watermelon, the next time you try to bite down on a watermelon, imagine the first time you bite it out, the liquid is the one that comes out and you swallow that liquid first. But you cannot swallow the flesh of the watermelon, the fibrous part, the same time you swallow that liquid. So this is when it is both solid and liquid at the same time. You have to chew and chew until all the liquid comes out, and then you have to chew some more for the flesh of the watermelon to be ready to swallow. So the watermelon, oranges, things that have fleshy parts and juicy fruits, take note that they may be mixed textures and may be difficult for some of our children to manage, all right? The second type of high-risk choking food texture is round or long-shaped food, okay? These foods are easy to slip to the back because round and long, they are slippery. So if I don't have enough control in my oral phase, my mouth, the tongue, the jaw, the cheeks are not able to manage and keep my food there properly, it may slip back accidentally and it can get stuck in my throat before I'm ready to swallow. So remember just now I said when you're ready to swallow, the body will close up the airway as well. So this is when if I'm not ready to swallow, then it might just slip in and get stuck. So this is very dangerous for choking. So cut the shape so that it is no longer round. So see here, this is the grape. And remember, they are all our food pipe and our windpipe, they are all tubes. They are like round pipes like this. So if your food is round and it gets stuck in this round hole, then it blocks out the entire throat. I won't be able to breathe. And this is very, very dangerous. Okay. So cut your round and long shaped foods into 4 parts like this, okay? Or half sideways. If you cut it this way, where it's cut in half, you say, oh, Yvonne said cut them in half. I cut them in half, but it still maintains this round and long shape at this end. Remember, it will still go down this part of my throat and it will still get stuck and the child will not be able to breathe if they have it stuck in their throat for some accident. Okay, so take in mind, cut it up. Ideally, just cut it up to 4 parts or half. So this is really a risk, and I'm not trying to make things sound scary. Typical children in nurseries, they are still choking to this day on round, long-shaped food. So just in November this year, a 2-year-old, she choked to death after eating a sausage. A sausage got choked in her throat and she passed away from that. In Japan, also the latest one was only in September. The grapes in the toddler choked on a grape and passed away as well. So don't think that, oh, you know, my child is eating. So this toddler in Japan, he was 4. He was already 4. So you think by 2-year-old, they should be able to manage table food, but still be mindful of how you prepare them. Cut them up and don't give them this kind of textures. Make sure it's properly cut up until you're very sure they are very mature and ready. So after they are 4, I'll be a bit more relaxed. Before they are 4, cut up and make sure you avoid all these highly choking foods, okay? Now, the second thing that you can start applying today is posture. Remember, if I lift my head up, I told you about the dangerous zone where the windpipe and the food pipe share a common area. If my head position is up, it increases the space and the chance for the food to go inside the windpipe, okay, into the airway. So this is a dangerous place for my head. If it's looking upwards, what I want is my head to be down. Looking forward, your chin should be down and midline. Your head shouldn't be left or right. Then because this way the food can go all the way. It can move all over the place and there is a chance that it may then accidentally go into the windpipe. So you always want to avoid them, avoid the neck going upwards, moving around. It will also facilitate when my head is stable and is looking midline, a proper jaw, lip, tongue movement. It teaches my child how to manage and build that oral motor control to manage food as well, okay? So now I talk about head position. Now, if you make sure your child's head is straight, and you say chin down like this girl here, chin down, head straight, but the body is not supported, then it is still not good for feeding as well, okay? You need to make sure that your feet is supported. So this way you say, okay, if you want to say support, I give them the chair booster, but your feet should also be supported. Why? You need a stable base. Your head is resting on your body. You need that stable base in order to manage how to chew. If my body is moving around, it will be difficult for my jaw to be stable and manage the food that I'm managing. It will also encourage more tension. I may be using different movements or different muscles that may not be necessary or good for chewing. So what you want is the 90-90-90, my favorite. 90 degrees at the hips, 90 degrees at the knees, and 90 degrees at the feet. So your feet should always be supported. your knee is flexed, you're not over flexed or under squatting down like this. Your hips are also in a good bent position. So if your child is in a wheelchair, it's also okay. You're tilting them as long as you get that 90 degrees as far as possible. You are providing a stable base from your body to your head, which then provides the stable base for your jaw to develop the movement that it needs to. Okay? So the takeaway points for today's presentation is be mindful of your feeding development, what to take note of, start introducing solids early, wean off the bottle by the time they're 1, do not prolong time with the bottle, know and appreciate how it can affect feeding and speech later on as well, and as well as the oral structure of the mouth. Be aware, I want you to be aware of the different phases of swallowing and know what is dysphagia. Take note of the red flags. Observe your child the next time they eat. Are they showing any red flags of dysphagia? Be aware that there's a range of causes. It's not always, oh, my child is being naughty lah. They just don't like this person's cooking. There may be a reason behind that. So have a chat with your speech therapist if you're concerned as well. Know the high-risk choking foods to avoid. Take note to encourage good posture for feeding. Okay, so I hope you have understood, and thank you for joining me and your attention all this while. Now we'll be going on to our Q&A section where we will answer some of the questions.
Yes, thank you, Yvonne, very much for the sharing. There's a lot of information. So I hope all of you will spend a few minutes to digest them and send in your questions. Yeah, in the meanwhile, we have a few questions here that we might want to answer. Okay, the first question, is it normal for a 1-year-old child to always gag on new food? That's a very good question that we are asked quite often. Let's have Yvonne to answer that.
I would say the first time it wouldn't. I personally say it shouldn't be gagging every time you introduce a new food. It is telling me that something we may need to look at what's going on in the mouth. Is it oversensitive? Where could it be I'm not introducing enough textures in the mouth? So to the child, everything that's new, it's too much overload already, and I'm like, oh, I cannot take it. Sometimes it could be the utensils that we're using. So we have to look at also what type of food, how often is this child being exposed to new food? Is it only every once in a while you introduce one new food and they get, and then 2 weeks later you try again and then they get again? So, but is it normal? I would say no. By 1, they should be familiar. Remember our transition feeding at 4 months, I'm already starting to introduce puree food. So that's where different taste is coming into my mouth. I'm starting to learn to manage different tastes. By the time 6 to 9 months, I'm learning different textures, so taste is what it tastes like, and then textures is what it feels like. So by the time I'm 1 year old, I should have at least a good 6 months being exposed to all these already. So gagging at that time would not be a normal process for me.
Yeah, that's right. I also like to add that by about 1-year-old, the gag reflex will have moved to quite at the back of your mouth. So it should not trigger the gag reflex so much when you introduce a new food. So not quite normal, I would say. So you might want to get someone to check that out. Yeah. And also think about all the various factors that Yvonne has shared, like whether you're introducing new food, how you're introducing it, whether it's a spoon, it's the taste, it's the texture. Yep. Okay, hope that answers your question. And then we have the next question. Should I introduce semi-solid puree to 10-year-old child with developmental delay who has no teeth? Right, let's have Yvonne answer that.
Okay, so we are saying that it's semi-solid purees. This is an interesting term for me. So I would want to see if you're talking about puree where it is smooth and there is no lumps in them, then I'm okay with introducing them because this one does not require that much of the teeth involved to manage that food. So I'm talking about pure smooth puree. So again, there is the IDDSI website. You can type in and they will tell you what is puree food, what is a proper puree. Essentially, when I lift it up from my spoon or I pick it up from a fork, it is almost able to fall through. That is puree a little bit already. So that I'm not talking about a bit of lumpy, too much lump or things that they need to bite. I'm okay with introducing semi-solid purees in that term to a 10-month-old child. It then essentially make sure you're not giving them things that require teeth. Since the issue we see here is that he has no teeth, then we give them a little bit of purees. As they are getting used to those smooth purees, along the way, you can check with your therapist as well. You can start to introduce a little bit softer things like tofu or really, really soft, very mashed up fish, very steamed very well. So where you can actually just mash them with your gums and it will be able to swallow. So then that's where sometimes that interaction on the gum, that different texture can also start to initiate that teeth eruption process as well. So smooth purees, yes, go for it. If you are going to introduce a little bit of lumps with some soft solids, then monitor. Make sure your therapist is there to watch and make sure that there's no signs of dysphagia. And make sure that your child is able to manage it. So check if they can. If they cannot, then stick back with the smooth purees until they are able to manage a little bit more of lumps. Okay, I hope that answered your question. Anything to ask?
Yeah, that's right. I think we need to slowly increase the texture of the food from quite liquidy to something that's a little bit harder, and then eventually something that is munchable. So like Yvonne shared, like steamed fish, tofu, that you actually can use your the roof of your mouth and your gums to just mash it to be small enough and soft enough to be swallowed, even if the child has no teeth. So just remember to increase the texture slowly and not rush it. Yep. Yes, so we have another question. Um, how do we differentiate picky eaters versus the child who may have difficulty in swallowing the food? Good question. I like this. Okay, let's have Yvonne answer that first.
My answer would be please have a chat with your speech therapist. But essentially, what I will do when you bring a child in and I'm thinking, oh, I wonder if it's just purely picky or is it difficulty swallowing the food. I would do an assessment of the oral motor system to see if it they cannot manage. So I will then look and see are they able to chew as many times as they are required to chew. Are they able to move the different parts of the mouth? So this is what we mentioned just now, actually one of the approaches where it's talking about a pre-feeding program. So before we actually even bring in food, we use tools to check, is my oral motor system ready? So how I differentiate is I will do an oral motor assessment to check is the jaw, the lips, the tongue, is everything in place? Are they ready and do they have sufficient coordination and strength to manage the food? And then could that be why? So I will also analyze what type of foods they are eating to see is there a trend? Only this type of food they don't like to eat. And then I can think, is it this type of food tend to be harder? Could it tend to be more liquid? So usually when I can start to see a particular type of food, a characteristic, that may be another hint to me that they can also be having difficulty with managing that type of food. Okay, so essentially I will do an oral motor examination to check is the mouth able to manage, and I also analyze what type of foods are they able to eat, not able to eat. How do you think?
Yeah, that's right. Like Yvonne had shared earlier about the different stages of feeding, of swallowing. So when you look at picky eaters, often they do have difficulties in the oral phase. So they have difficulty moving the muscles, accepting the different texture. So that could be different when you talk about swallowing the food strictly, which is like the third stage of feeding and the swallowing process. So if you are looking something after the swallow reflex, then we might have to send the child to a hospital for what we call a video fluoroscopy, where we have an X-ray to see whether the swallow function is working well and if there's any difficulties in the area. That will also help us differentiate the causes of why the child is not eating well, yeah, to help make a differential diagnosis. Yep. Yes. Hope that answered the question. The next one. Okay, when the child is doing extra laughing, the food will fall out of the mouth. What is his problem? That's a good question. I mean, like, personally enjoy having meal times with my niece, and she's like 7 this year, and she doesn't watch the YouTube or TV when we eat. So we always talk and chit chat, and then we do have like big laughter, and that is not uncommon for me to see. So I'll have Yvonne to answer this question.
Okay, so what I do see here is actually this participant is asking with when the child is doing extra laughing, the food will come out of the mouth, and after 1 hour, after 1 hour of eating and the child is laughing, the food will also come out of the mouth. So there are different things at this stage. The first one is while you're eating and laughing. So ideally, we don't promote too much laughing while the food is in the mouth. So we need to concentrate.
Yeah, very dangerous.
Yes, this is also where I start to ask my parents, please let's not give the iPad in front and distract them when they are eating. So if you're distracted and you cannot pay attention, remember my first 2 phases of swallowing, it is voluntary. So my mind is involved in the feeding. So if my mind is elsewhere, then my mind might spread the resources, and I may not be coordinating the mouth as well, which may be why the lips forgot to close and the food may be coming out as well. So if he's laughing all the time while eating, I'll say, okay, let's calm down, wait until you're not laughing, and then repeat. Okay, so get them to focus and concentrate. And if a lot of things are spilling out of the mouth, take note of how is the lid closing. Is it able to keep the food in the mouth, or is it not able to keep the food in the mouth, and that's why the child is laughing. So differentiate why the child is laughing and why the food is coming out. And if 1 hour after your child has finished eating and you see when they laugh, the food comes out, then I would wonder, is the laugh trying to cough out food or trying to spit out the extra food that's in the mouth? And this will tell me certainly there is something going on in the swallowing process where the food was left over. So remember, one of my red flags is if there's leftover food in your mouth after you swallow. So that's telling me the first phase where you were supposed to bring all the food together and swallow was not probably done well, or they may have kept some food pocketing here, or it could be he's laughing so hard and it's coming back from the throat also. So all these would tell me definitely a red flag. After 1 hour of eating, I do not expect food to be coming out of the mouth anymore. Actually, ever, even when the feeding process is going on, also we try not to have that. So first thing to try, make your child pay attention when eating so that they are focused and keeping attention, and take away any distractors. If they are looking at iPad or laughing, or somebody is playing a funny show, look at the funny show, finish laughing, then eat. Okay. After that, then we will ask them to focus and swallow and clear everything before they continue. I would suggest you bring them to the nearest speech therapist also, and let's look at why after they are eating 1 hour, they're still laughing out food. Okay?
Yeah, that's right. Usually when after a meal, we recommend a child to be seated upright, like don't go lie down immediately after you eat. So in about 20 to 30 minutes, the food will have gone down to your stomach and then start moving through your intestines. So if after an hour the child is still having food coming out, and if the reason is like food has come up from the stomach, then there could be something that is inside the digestive tract that is not working. Because we do have a sphincter muscle that close off the stomach, so that food don't come up. But if the child still experiences that, do get checked out by a doctor actually, because it could be something medical. Yeah, we do have some children with that issue. We call it GERD, and then the doctors would actually recommend medication to help the food sit down in the stomach. And some more severe cases, we even have them to do surgeries to tighten up the muscles so that food do not regurgitate out. Yeah. But overall, when you are eating with the child, two things that you could do is to make sure that they focus and eat, and then also that they be engaged and sit upright for the next at least 20 to 30 minutes before they go take a nap or they roll around on the floor playing. Yeah, some parents are quite good with rough play, and I love that engagement when they do rough play, but not too rough after meal, okay? Yeah. So hope that helps. And all right, we have another question here. Okay, this is about 18 months old baby, and he bites food, makes soluble only with his tongue, and sucks liquid and then spit out the solid. Can I get some suggestion for that? So I think this participant is saying that based on my experience, I see a lot of children doing that, where they bite a piece of food, they munch, or chew, then they swallow the liquid, the juice from the piece of food, and then they just spit out. This is especially common for meat, when they eat meat. Yeah, so Yvonne can give us some ideas of how we can help this child.
Usually, as we think here also, it's common, and it's because sometimes there's the solid that is left over, it might be too tough for them to bite and break down. So if you're talking about maybe those orange, even the orange flesh, sometimes if you bite it, that fiber, to this day, sometimes I don't eat the fiber as well. Confession.
Me too.
So it could be because it just takes too much effort from the jaw to have to bite and bite and bite and try to break down, and then there is no taste anymore. Like the favorite part of my orange is the juice. So the liquid is what I'm looking out, and the solid, if it's taking too long and too much effort to bite, it is quite common to spit out. So I'm generally usually okay. I would say it's only a problem if he spits out every kind of food that they eat. So be mindful, is the child, if your child is only 18 months, I'll give him a little bit more time. So by 2, I will start to expect them to be swallowing all the solids as well. 18, they may be still learning and strengthening the mouth area to be able to manage. So don't force them to eat the solid. If they spit it out, that is their natural reaction telling you, I cannot handle this. So I always respect when children spit out the food. I don't force them to put it back in, because their body is saying, I cannot manage this. So it tells me that they may need some exercises. So in this case, it's essentially sometimes more experience eating this food can also help to build that experience and that strength. Sweetie.
Yeah, that's right. At 18 months, I wouldn't be giving my child like adult kind of meat, like in pieces, even though it's cut small. I would still prefer to cook minced meat, or meat that has been like braised for a very long time until it's really soft, where all the fibers are gone. Like for fruits, I've read some website that they say take away the thin film that divides the pulpy part. Yeah. So 18 months, I would not expect the child to be able to manage the adult kind of food. But like what Yvonne said, by 2 years old, I would expect them to do so. That's when we say the child can accept what we call table food. So food that all the adults eat, just that is cut into smaller pieces. Yeah. So for now, do keep a lookout of what you give the child. I also maybe have Yvonne to write down in the chat group the website that she suggested, that she mentioned about the different texture and consistency of food. Yep, I think that would be a useful resource for everyone here. Yes. I think we are about time. Maybe we answer one last question. Okay. Should I teach my child cup drinking even if he can already drink from the straw? That's a question that a lot of parents ask me often. So maybe we can have Yvonne share a bit about whether you teach the child cup drinking.
Whether I will teach the child cup drinking?
Yeah.
Yes, I will always teach the child cup drinking. They will need both. So parents have also asked, my child can drink from a cup. Do I need to teach them to straw? So these are essential skills as when we look at why we are doing therapy, is to maximize their potential for future. As they grow up, I want your child to be able to drink from a cup. You are able to drink from both a cup and a straw, and so should your child. Your child, just because he's getting liquids through the straw doesn't mean he doesn't need to learn how to drink from a cup next time. So this is definitely a skill that I would want to teach. Cup and straw, they also target different mouth movements. So straw, I'm looking more at this and sucking that round lips you're going through, holding the jaw there. Whereas cup, you're talking about your lips, the top and the bottom differentiating, being able to do that movement, tilting your head and managing that. So they will learn different skills with different utensils. At the end of the day, all the children that I work with, I ensure that they learn how to do both. Unless absolutely necessary, then we try to choose one. Otherwise, all adults use cup and straw. Your child should also use cup and straw as well. Yeah.
That's right. When you think about the long run, it's only functional that we do both. Unless the child has got some structural issue and has difficulty doing both. So for me, some of the children with cerebral palsy, they have not very good posturing. So straw may be better for them with better control. Cup may be difficult because of the posture. Then I would not teach cup, but otherwise I would definitely teach both as well. Yeah, it's functional only. Okay, I think that's all for today, and we hope to see you all again soon for our next webinar series. We are targeting ASAP. It's a secret, yes. So everyone, take care, be good, and goodbye to my friends in Myanmar. I see a lot of you here, and shout out to all my Singaporean friends here too, and parents. Thank you so much. Bye, take care.